everyone. Today I am going to continue our topic beta blocker drugs. I already listed many drugs in the beta blockers and with their mnemonics. And today I am going to discuss how these drugs works on the angina and the congestive heart failure patient. So in this video, first I will discuss how the SA node, AV node and the Purkinje system and the ventricular myocardial cells, how it works normally. Then I will discuss how if we give the beta blocker drugs, then how it alters the action of these, the SA node, AV node, Purkinje system and the myocardial cells, and mechanism of this beta blocker drugs, how it works on the angina and the congestive heart failure patient. And we will also discuss the side effect of these beta blocker drugs and in which condition we have to avoid these beta blocker drugs. In everything I will discuss in detail in this video. At first I will discuss how this beta blocker drugs works in the angina patient. Then later I will discuss how these drugs works in the congestive heart failure patient. I already discussed about this beta receptor in my previous video. That is, the beta receptor is divided into beta 1 and the beta 2, and the beta 1 mainly located in the cardiac cell and beta 2 located in the bronchial smooth muscle cells. Now I am going to discuss in angina how the beta blocker drugs works. Before that, we have to understand how the beta 1 receptor works on the heart normally. So first we have to understand how this beta blocker works on the heart. So first we know that the norepinephrine comes from the nerve ending and the epinephrine comes from the adrenal medulla. From the adrenal medulla it goes to the circulation, and from the circulation it goes to the blood circulation all over the heart, and then the norepinephrine and the epinephrine both acts on the beta 1 receptor at the SA node side, and that lead to the positive chromotropic effect, and that lead to the increase in the heart rate at the first event. And second, this beta 1 receptor stimulate the AV node. When the AV node is stimulated, that lead to the positive chromotropic. It means here the AV node that lead to the increase in the conduction from the SA node to AV node, and that lead to the positive chromotropic effect. And the third, this is the first, this is the second action, and now at the third action it acts on the contractile myocardium cell here, and that lead to the increase in the contractibility of the heart. When there is increase in the contractibility of the myocardium cell here, that lead to the positive inotropic in the heart. So now we have to understand what happens when the beta 1 blocker drugs acts on the cardiac cells, on the heart. I already discussed before, the beta 1 blocker drugs is called selective drugs. In this case, it only acts on the beta 1 receptor in the low dose. If we give the high dose in the patient, that lead to a block of the beta 2 receptor also. So in low dose it only block the beta 1 receptor. So now we have to understand what happens when the beta blocker drugs is given in that patient, in the angina patient. So first, when the beta 1 blocker drugs is given to this patient, first this beta 1 receptor is get blocked. So there is no more action of the non-epinephrine and the epinephrine. So there is negative. So now it will causes the negative. That will lead to negative chromotropic effect, and that lead to the decrease in the heart rate. And now there is also the decrease in the conduction at the AV node. So what happened? That lead to also decrease in the conduction in the AV node. That lead to a negative that lead to negative here now, that lead to negative dromotropic effect at the SA node. When there is the low conduction at the SA node, that lead to low contractibility at the myocardium cell, and that lead to decrease in the contractibility of the myocardium, and that lead to the negative inotropic effect on the heart. So beta 1 blocker drugs can reduces the electrical as well as mechanical activity of the heart, and that lead to the negative chromotropic effect, and also in the electrical effect that lead to the negative dromotropic effect, and for the mechanical effect that lead to the negative inotropic effect. And when there is the reduction of the heart rate, when there is reduced heart rate, that lead to a decrease in the stroke volume, that lead to the decrease in the cardiac work. If there is the decrease in cardiac work, so there is reduced need of oxygen, and by this process how this beta blocker drugs works in the angina patient, and the patient can get relief when we are giving this beta 1 blocker drugs in the angina patient. So this beta 1 receptor blocker drugs, it reduces the cardiac work of the heart, and that lead to the reducing the need of the oxygen, and so this beta 1 receptor blocker drugs also prevent from the myocardial infarction. So this drug is also very useful from prevent the myocardial infarction. And we have to understand one thing also, we cannot stop suddenly this beta 1 receptor blocker drugs, because by the norepinephrine and the epinephrine it get high stimulated. The beta receptor get highly stimulated, and that lead to the higher contractibility of the heart, and there will be the increase in the cardiac work. So there will be increase in the need of the O2, and in this condition there is the chance of myocardial infarction. So we have to understand that we cannot stop this beta 1 blocker drugs suddenly. Now I am going to discuss about the congestive heart failure, how this beta blocker drugs works in the congestive heart failure patient. So first we have to understand what is going on in the congestive heart failure patient. So in the congestive heart failure patient, we know that there is the less cardiac output. If there is a less cardiac output, then there is the sympathetic nervous system get activated. Initially, when the sympathetic nervous system get increases chronically, it is beneficial for this congestive heart failure patient. If that happen for a long time, then there is the dangerous complication in the heart, and that lead to the pathological change in the cardiac tissue, and it undergoes progressive heart failure, and it affect the normal function of the heart. And now we have to know how the drugs works in the congestive heart failure. These are the drugs mainly used in the congestive heart failure patient. In the first, the labetalol. This labetalol is used when the patient is hypertensive. That is when the patient have blood pressure 180 over 120 mmF Sg. When there is the patient is hypertensive, and this labetalol is also safe for the pregnancy. We can give this labetalol in the pregnant woman, and this carvedilol is used in the both condition. The patient with the congestive heart failure, and the patient with hypertension. Patient with hypertension, the congestive heart failure patient, it is very useful, the carvedilol, and it has also antioxidant property. It has also antioxidant property, So it reduces the ROS action, reactive oxygen species, because this ROS helps in the oxidation of LDL. When the LDL get oxidized, that lead to the atherosclerosis, that lead to the hardening of the blood vessel. There is the deposition of the hardening of the blood vessel, and that causes also the blockage of the blood vessel. So it reduces the chances of the atherosclerosis. And we know that the labetalol and the carvedilol is the non-specific drug. It can work on the both alpha and the beta receptor. So when the labetalol and the carvedilol works on the precapillary sphincter, when this labetalol and the carvedilol works on the precapillary sphincter, here is both alpha and the beta receptor. When this labetalol and the carvedilol works on the alpha receptor, that lead to the dilation of the blood vessel. And when the blood vessel get dilated, and also the total peripheral resistance get reduced, so blood can pass easily and the afterload get reduced, because the blood can flow easily, so there is also reduction of the afterload. And the propranolol used in the anxiety patient, because this propranolol reduces the sympathetic system action, so there is reduction of the palpitation. It also reduces the chest tightness, and it also reduces the shortness of the breath, and is used in the migraine patient. Now we have to understand in which condition we have to avoid these beta blocker drugs, and later I will discuss what are the side effects of these beta blocker drugs. So the patient with asthma or COPD, we have to avoid these beta blocker drugs, and also in the diabetes mellitus and the Raynaud's phenomenon, I will discuss later what it is, and in case of the bradyarrhythmias and the depression, we have to avoid these beta blocker drugs if the patient have this type of disease. So now I am going to start from the asthma or the COPD. Why we have to avoid these beta blocker drugs in the asthma or the COPD patient? Normally, the beta 2 receptor present on the bronchial smooth muscles. These beta 2 receptors are very rich in the bronchial smooth muscles, and when the endogenous catecholamine get stimulate this beta 2 receptor, then there is the beta 2 receptor mediated bronchodilation occur. And in the normal patient, when we give this beta 2 receptor blocker, then there is slight loss of the beta 2 receptor. But if we give the beta blocker drugs in the COPD or the asthma patient, there is already loss of the elasticity of these bronchioles. When we give these beta blocker drugs, that prevent from the bronchodilation, and that lead to the narrowing of this bronchiole, and here is no more beta 2 mediated bronchodilation occur, and that lead to the strong vasoconstrictor, and later due to this vasoconstriction lead to fatal in the asthma and the COPD patient. And in second, diabetes mellitus. Why we have to avoid these beta blocker drugs in the diabetes mellitus? So before that, first we have to understand the normal physiology of the liver and the pancreas. We know that the epinephrine is released from the adrenal medulla, and this epinephrine undergo in the circulation, and it acts on the liver of the beta 2 receptor. When this beta 2 receptor get stimulated by the epinephrine, that beta 2 also stimulate the hepatocyte in the liver, and that hepatocyte lead to glycogenolysis, that is the breakdown of the glycogen, and breakdown of the glycogens through the glycogenolysis, it produces the glucose. And also this pancreas has the beta 2 receptor. When this epinephrine also acts on the beta 2 receptor of the pancreas, it lead to production of the glucagon, and this glucagon acts on the liver again. And now in this condition, there is no glycogenolysis. In this time there is the gluconeogenesis, that is the breakdown of the amino acid, lipid, fatty acid, and that lead to the production of the glucose. When we give the beta blocker drugs to the diabetes mellitus patient, there is no more activation of the beta 2 receptor of the liver and the beta 2 receptor of the pancreas. So there is no more production of the glucose, and that lead to hypoglycemia in this patient, and later they have more chances to undergo in the coma condition. So we have to avoid the beta blocker drugs in case of the diabetes mellitus patient. Third is Raynaud's phenomenon. In this condition there is the peripheral vasospasm. In that condition our hand is feeling cold, or we feel the painful extremities. So in this condition, if we give the beta blocker drugs, that lead to severe condition. So we have to avoid also beta blocker drugs in the Raynaud's phenomenon. Fourth is bradyarrhythmias. This is very easy to understand. Suppose this is the right auricle, this is the SA node, and this is the left auricle, and this is the right auricle, ventricle, and this is the left ventricle, and here is the AV node. This is the SA node and this is the AV node, this one. So in this condition there is already slow conduction, so there is low heart rate, so there is reduced heart rate. If we give the beta blocker drugs in this condition, that lead to the severe reduction of the heart rate, and that later lead to the heart blockage. So there will be no any impulse from the atria to the ventricle, and there is no more contraction of the ventricle, and that lead to severe condition in this bradyarrhythmia patient. So we have to avoid this beta blocker drugs in the bradyarrhythmia patient. Fifth is depression. Why we have to avoid these beta blocker drugs in the depression patient? We know that one of the side effects of the beta blocker drug is the depression. If we give the beta blocker drugs, the patient will go in the more depression, and maybe that may commit to suicide. So this is very harmful for the depression patient. So we have to avoid the beta blocker drugs in the depression patient. The side effect of the beta blocker drugs, first is the fatigue, second is the sleep disturbance. When this beta blocker drugs goes to our brain, that causes the sleep disturbance, and that lead to the insomnia of the patient. And next is the depression, and another is the impotence. That also lead to the erectile dysfunction. These are the side effects of the beta blocker drugs.